developed self-care guideline, and from that, Uganda adopted and also developed a national self-care guideline. Next slide, please. Yesterday we had a panel discussion on self-care, and I believe we got a lot of information on that. But just by way of reminding ourselves what self-care is, the ability of individuals, families, and communities to promote health, prevent diseases, maintain health, and cope with any illness or disability with or without a health worker. So self-care is telling us we have a lot to do as individuals, as families, and as communities. And personal health literacy refers to the degree to which individuals have the ability to find, understand, and use information and services to inform health-related decisions. All presentations that we have been hearing from day one relates to the decisions that we make. And then the organizational literacy, health literacy is the degree to which organization equitably enable individuals to promote, prevent diseases, and promote health in that particular community. So these are the broad concepts of self-care. We look at the hygiene, we look at the nutrition, the lifestyle. I wanted to just show you a bit of a video of what took place in Dokolo when we had the national self-care awareness and we had all the big shots jumping up and down. And I had requested that probably we start with that, with a bit of aerobics, but I was told time is not with us. So the lifestyle matters a lot. And then, can you please go back a bit? And the socio-economic factors. When you don't have money, you know what it means. When you have money, you know what it means. So the socio-economic factors also affect how your health lifestyles are. And then the self-medication. Most people think when we talk about self-care, we are talking about people going to buy medicines and swallow. No, it's all about adherence to your medication that has been prescribed by the doctor. So this is a slide talking about the 5 drivers. What are the key 5 drivers that we need to consider for us to ably say self-care is taking root? One of them is health literacy. People need to know. Unless they know, they will not do it. And from the previous presentations you've been hearing, people lack information. Even within the health profession, we also need to know certain things. We don't know it all. So knowing is very important, and that is health literacy. Then the healthcare professionals who are on the front line to ensure that self-care takes place. And then the healthcare system, and that's why we are institutionalizing self-care in the health system, and the products and the medication that goes with, and of course, technology. Next, please. So what is the vision of self-care like in the country? Next slide. Uganda's self-care vision talks about the accelerated progress towards universal health coverage. If we must achieve the universal health coverage, there are key things that we need to do as individuals, as families, and communities. It's not only the role of the health system that can lead us to where we would like to be. And then strengthening the primary health care, management, and multi-sectoral collaboration. And finally, integrating self-care into the existing health system. Next slide, please. So this basically talks about the journey that we've had so far, that from the launch of the WHO consolidated guideline on self-care, as a country, we integrated stakeholder engagement for buy-in and to understand that globally we have a self-care guideline. After that, then we formulated self-care expert group with the Secretariat at Population Service International. And this has quite a number of partners: Makerere University School of Public Health, PATH, with the leadership of Minister of Health and other partners. And then we selected our primary focus being sexual reproductive health. And after that, we started on the process of developing the guideline, and as we speak now, we have the guideline in place. which should have been launched here, but because of a few other additions, they are in. Next slide, please. So what are the approaches that we would like to undertake in implementing self-care in the country? One is coordination that must be led by Minister of Health, and this must be multi-sectoral. We have Minister of Gender, Labor and Social Development, we have Minister of Education, National Population Council, MPA, and many other partners, including the university. And then access and utilization of the self-care intervention being implemented in both private and public facilities, and then the measurement of monitoring and evaluation, including learning, so that we get everyone on board. And then supply chain management, how do we quantify for the commodities that are required, and then follow the supply chain management until last mile. And of course, quality assurance, digitalization, and health promotion. So those are the various approaches that we think when we follow as a country, we should be able to institutionalize self-care. So the different priority areas, we have family planning, antenatal care, HIV and STI, post-abortion care, and NCDs. NCDs, we are basically looking at hypertension, diabetes, and mental health. WHO Global has incorporated care for the older persons, but as a country, we may not embrace all that at a go. So we would like to go slowly, and in NCD, that is the section that we have added, and we are only going to look at the 3 that I've mentioned. Next slide, please. So in family planning, I don't want to go through the entire slide, but basically what this slide talks about is that when we are talking about self-care in family planning, we talk about self-awareness, self-testing, and self-management. That what are those key things that a woman or man must be able to consider under family planning component or priority. One of them is basically basic information and self-awareness, facts about family planning, the myths and misconceptions, demystifying that, and then use of digital platforms. And under self-testing, you all know, for one, to prove that you're pregnant, within the initial stages, probably you need to do HCG test, and this is something that a woman should be able to do by herself in her room. And then weight and home-based ovulation predictor. And then on self-management, how do you manage yourself? We have what is called Soyana breast, DMPA-SC, where women inject themselves with the contraception, which is for 3 months. And this has proved very effective in the country, because we have quite a good number of women who have enrolled into self-injection, and we are happy that self-care is taking place. Next slide, please. Under antenatal care, we know that a lot takes place around antenatal care, and women need to do a lot for us to have safe delivery, for us to have good pregnancy outcome. So under self-awareness, they need to know the key things, specific information, birth preparedness plan, they need to know the danger signs, they need to know issues around nutrition, sleeping under treated mosquito nets, and then HIV prevention and PrEP. And finally, when they deliver their baby, breastfeeding. And in self-testing, all those are the issues that we look at. Next slide, please. For HIV, also, we have HIV self-testing. You are all aware, people are testing themselves, but of course after testing and there is any disagreement, they can go for confirmatory test. And I don't want to dwell on this, it's very clear. Next slide, please. Next slide, please. Next slide. Post-abortion care, also specific health information that women need to know, causes and risks, the prevention, linking them to post-abortion care and return to fertility, and how to get to the best, how to get referral to the best facility in case of any complication. And management, basically that. Next slide. I'm trying to rush because of time. JP, you bear with me. It's delaying me. So NCDs, like I said, is what we've added as a fourth priority. And here we are looking at mainstreaming self-care in NCD prevention and management in all sectors, looking at the social determinants of health. What are the key things that people have to do? Yesterday we were laughing on my table. There's a WhatsApp going around that Rwanda has established a whole lane for jogging. And people are like, we also need it in Uganda. And others are saying, no, you can do this in your own house. You don't need to go in the road. I always tell people that I dance. Before I take my shower, when I reach from work, I first do Rio Pepe Kale, and after that I take my shower. And that is exercise in its own. So I don't need to go on the road. Then we have building capacity, advocating for investment in research, and increasing awareness on the merits of early detection of NCDs. Next slide, please. Next slide. So the update, like I said, World Health Organization developed the guidance. So World Health Uganda will be able to continue supporting us. And then advocacy and technical engagement, supporting skills building is what we are now moving towards. Next slide. WHO will continue supporting us in implementing holistic self-care that will include SRH, non-communicable diseases, mental health, and health of the older persons, like I said. And then at country level, our support will be focused on implementing the National Self-Care Guideline. Next slide, please. Next slide. So in terms of advocacy, we have SEHAD Uganda that has been leading on advocacy for self-care. And these are the following milestones that we have achieved from their advocacy. They have created awareness, they have reached out to the members of parliament, they have reached out to the media, they have had media engagements, and so many other approaches. That has helped us to position self-care at another level. Next slide, please. Implementation has been done. We have had first phases taking place in 2 districts of Mukono and Kayunga, and the district leadership are on board, the health workers. You had in the panel discussion, we had one of the very good health workers, the promoter of self-care in her district, and that's what we want to see happen in all other districts. The other day I was in Busia, and Busia, I can see all of them in the room. They were so enthusiastic, interested, and ready to position self-care high on the agenda. And I told them, yeah, we shall reach out to you. So I call upon all of you to look at what are those small things that you can do to promote self-care within the leadership, within the staff at the district level, but also other community. Next slide, please. Yeah, this is the last mile assurance, one of the things that we've done. Following commodities for self-care in the country. What are those commodities that we are interested in, and are we having
field exercise, and I found NMS had delivered HIV self-testing in the last 5 months, and they had not even touched a single kit. And my challenge to them was that these kits were not given to you to keep them in the store, but you are supposed to give them to the community. You have VHTs, you have all that. So colleagues who are in this room, please ensure that when you receive these commodities, they are taken for the right reasons. The HIV testing should be able to be taking place. The other commodities should be able to be utilized. Next slide, please. The best practice so far, self-care, continued medical education. This has created space in some facilities, trained youth on HIV testing and management, and we've integrated self-care in other outreaches like immunization. Next slide, please. Trying to rush. Lessons learned. Let's go to the next one, please. Challenges are enormous, but I think as from this conference, we should be able to now do business unusual. We should be able to go and work closely with all our stakeholders right from the store. If the commodities come, where does it go? Who is using them instead of just keeping them? Next slide. Next slide. Planned action as a country. We would like to support catalytic implementation of the guideline. The guideline is out. Next is to run with it, and all of us in the room should be able to do that. WHO will continue to support us. Advocacy, media toolkit development will continue. We shall do policy mapping, which are the policy documents that do not talk about self-care and how can we support multi-sectoral engagement. I already mentioned about the different sectors that are in self-care for us to be able to integrate in other health sector, in other government sectors, and creating enabling environment as very key. But above all, doing research. How can we do more research to be able to show evidence? Right now, as Minister of Health, we are going to do investment case to show the worth or the value or socio-economic benefit of self-care for Uganda. And the world is waiting for Uganda to show that, so that other countries probably can learn from us. So we are in the preliminary processes of developing an investment case to demonstrate that if Uganda embraces self-care, we shall avert so many deaths, we shall avert so many NCDs, we shall save government from the costs of treating complications. Next slide. So my call to all of us in the room is integration of the sicknesses among the older persons is important. Finalizing, approving, and disseminating the self-care guideline is key. Bringing different partners on board to support self-care should be our next move, and tapping on the social media platform. The other day, the young person told us how it is their space. Can we use that space to popularize self-care? Next slide, please. My next presentation is on postpartum family planning as a high-impact practice. Next slide. This is data that we know. We are happy that we've reduced maternal mortality to 189 per 100,000 live births. We need to do more. Unmet need has reduced, but our target is to reduce it to 10. Next slide, please. Our MCPR is still low, 38. We are happy, but not very. So we need to do a lot. So postpartum family planning, as has been discussed also in the panel discussion, this is the initiation and use of family planning methods for the prevention of unintended pregnancy, closely spaced pregnancies through the first 12 months. And the immediate postpartum is offering the voluntary contraceptive counseling and services as part of facility-based care immediately after childbirth. And the post-abortion family planning is offering the voluntary family planning, counseling, and services at the same time and location where women receive the facility-based services. So why are we emphasizing on this immediate postpartum and postpartum family planning? It's because it's been proved. Next slide, please. It has been proved as a high impact practice globally, and it is the way to go that as a country, if we target the women, we know that our institutional delivery is high. So if we target the women at the time when they've had their babies within the facility and give them the method of their choice, and knowing that this starts from antenatal, then we can reduce on unintended pregnancies. Next slide, please. I'm speaking, but just go on when I say next slide. Next slide, please. So this slide is basically talking about antenatal attendancy in the country. And as you see, the first ANC attendancy in the first trimester is still below 55% target. But we have, according to UDHS, over 95%. We have achieved that. And this is a huge opportunity that if over 95% are really attending antenatal. And talking about postpartum family planning starts at antenatal clinic, then this is a very big opportunity for us to get these women for early initiation of postpartum information and education. Next slide, please. Institutional delivery, like I've said, we have increased institutional delivery, and this shows you that if over 90% of our women are delivering in our facilities and we have targeted them at antenatal, then it should be a walkover for us to offer the services during, after their childbirth, so that they don't miss out on the opportunity of taking a method with them. Next slide, please. Next slide. So this slide is basically showing you the uptake at national level that has consistently remained low, and the highlighted one in red tells you that, wow, they are doing very badly. I don't want to embarrass any region, but you see it by yourself. We are not doing well. And my call to you at the end of this slide is going to be very clear. So we need to step up the efforts, not to miss the women who come for antenatal, not to miss the women who deliver in our facility, and make sure they take the method of their choice. It is our role as health workers. The women don't know. So if we don't give them the information, then they will not know. They will simply go away. And we need to go further to counsel. There is what is called MOT, counseling somebody to give her an opportunity to be able to make her own decision, empowering her to make decisions and say, no, I must go with an IUD. No, I must go with an implant. It is our role, not the women's role. Next slide, please. Next slide. Institutionalizing in immunization. You know, if we miss this lady, definitely she's going to come back for immunization. But what do we do when she comes back for an immunization? Do we just give the immunization to the children and let them go? That is a big missed opportunity. And I think all of us who are seated here, the other day the minister was taking pictures with the midwives. Midwives in the room, take note. When in immunization clinic, don't just concentrate on immunization. Let's integrate. Next slide. This is also showing you data. Next slide. Missed opportunities, like I've talked about, there is a huge potential. So the emphasis is integrating at any moment. Don't miss out on taking on these women with information. Next slide. So this is still in immunization, to integrate family planning at various immunization contacts. Because there are those who will come immediately, there are those who will come after 6 weeks, 10 weeks, 14 weeks, and 9 months. Because postpartum family planning starts from that day 1 up to 12 months. But we all know that there are women who are capable of getting pregnant within the first 6 months. So we don't need to miss out on those women. They should be able to receive a method of their choice. And of course not coercing. Next slide.
So there are challenges. Understanding the concept of the high impact practice is very important. And I think when we use all this platform, last month we had a webinar on this and the attendance was very good. So we need to understand why is the world telling us that postpartum family planning is a high impact practice. Because I've mentioned it. Getting this woman in antenatal, getting her at delivery, getting her at immunization when she comes back for postnatal. It's very important. Then understanding the family planning methods for postpartum family planning. We have the Make Will, we have the compendium. All those tools are there for us to use to be able to help and make a decision with the woman on which method she's supposed to take home. And then capturing data is yet low. Myths associated with family planning during postpartum period is too much. You all know it, the midwives, the doctors who are service providers, you all know this, but it's our role to demystify those myths and give the right information. Cultural barriers are enormous. We still live in a world where people believe strongly on their culture. We don't need to stop it, but can we help them to appreciate that within those cultural norms, there are those good ones that we can run with, but there are those ones that affect the health outcomes. And it's your role to do that. Then the provider's competency. I think this has been talked about so much in the previous days. We need to do mentorship, and people are calling upon Dr. Morocco, I hope he's in the house, to intensify further on-job mentorship to be able to build the skills and increase the competency rates. The opportunities available, we have policies that support postpartum family planning, so no one should lie you. At times health workers have the tendency of saying, but the policy does not allow this. We are not allowed to give contraception to young people. The policies are there. If somebody comes and wants a method, please, don't let her go and get pregnant. Judge, be able to judge the right thing to be done. Cost effectiveness, that's an opportunity because you are capturing the women within that service moment, within that service point. You don't need any extra resource to be able to offer postpartum family planning. And the expertise in enabling environment and enhancing advocacy. Next slide, please. Next slide. So as a team at Ministry of Health with partners, we developed a roadmap on how we can track implementation of postpartum family planning. And this came as a result of one presentation that Dr. Morocco made. And it showed that in the central region, the performance was very bad. And Dr. Jessica asked us to come up with a mechanism of how best we can support and ensure that there is uniformity, or we support all regions to be able to improve on their postpartum family planning services. So we did this in a period of over 3 weeks, and it's not very clear, but we developed this roadmap, and it is spelling out exactly. We started with the concept, had small groups for service delivery, for policy, for capacity building, and then agreed what do we need to do. As we already talked about competency, we already have a plan of how best we can build the capacity of our service providers to be in position to offer postpartum family planning. And then moved around that we presented this to the director, Dr. Laro, and then we requested that the next step, a circular be written to all districts that postpartum family planning is key. In antenatal, it must be something that everybody is aware about. In labor ward, everybody must be aware about. So, but do we need a circular to be able to offer certain services that we know is a high impact practice? If the circular has delayed, can we still embrace it and start immediately to implement? Because what we want to see is in the next 6 months, we'd like to see the regions that are lagging behind being the ones on top. And we would like to do all that it takes to support you to be able to do that. Next slide, my call to action is that all partners to continue innovating, to have the best family planning services, to increase our uptake for immediate postpartum and postpartum family planning in general, because it is a proven high impact practice. As a country, we need to emphasize monitoring and evaluation so that performance are monitored against the set target. If we have set target, which regions are lagging behind? And then in the next 6 months, we want to see an increase in utilization of postpartum family planning. We also want to see that each district improves. From the slides that I've shown, and I would request the Secretariat to share these slides with all of you, look at your district where you are, and then try to do something. It's not good for us to embarrass you here, but it's good for you to look at it, and say, oh my God, we are not doing well. And finally, IPs to take note to support these districts. We have so many partners. The other day, the PS was saying, and the minister, we have so many partners doing a lot of work in the districts. So we call upon all the partners to be able to support the districts to achieve on this. And with that, I want to thank you so much.
Another round of applause to... She's becoming our mother of self-care. Yeah, we are now getting those national champions to drive some of these critical agendas. Now, you might have realized that every person coming in has a cup of tea because it's quite cold. So if you're in here or you haven't grabbed a cup of tea, just walk out slowly. Get yourself a cup of tea and come and sit. It's going to be a working tea. We're not going to have any specific time for tea in the interest of time. So just walk out slowly, grab some coffee, come sit. As you take a sip, we shall be rolling forward. I would request the ushers, any of the ushers, to come and try guide on how our elders can get some coffee so that they can warm up a bit. Now, ladies and gentlemen, I want to hand over the session to the session chair, Dr. Olive Sentumbwe, so that he can take it on from here, and possibly he will guide on how we can have some questions and reactions to the very wonderful presentation that Rosalyn has made. Dr. Olive, over to you. A round of applause to Dr. Olive, one of our greatest safe motherhood champions that we've known in this country. Dr. Olive, over to you. I don't know where you prefer. Do you prefer to take the podium or do you prefer stand? All right.
Thank you very much, Dr. Bagala. And good morning, colleagues, ladies and gentlemen, all protocols observed. Dr. Rosalyn, you've done us well, and thank you very much for the presentation on both PPFP and self-care. Colleagues, the session is open. If you have any remarks, if you have any questions for Rosalyn, she's willing to take up 2 or 3 questions. And as you show the hands, we have appreciated that the older person in Uganda is 60 plus. Eh? So how many older persons are here for self-care? Okay, we have about 4 hands now. Can we have them? There are about 4 hands. Is somebody coming with the microphone? We have Dr. Mugasa, we have Professor Pius, we have Professor Josephat. I saw another hand there and another one here. So in that order, we have 5 hands. Thank you. We'll start with you, our teacher, Dr. Mugasa. Do you have a mic? No. Our colleagues, organizers, we need the mic.
have the mic.
Yeah. So 60 plus is older persons in Uganda, according to the policy of the Ministry of Gender, and therefore the government of Uganda. Okay.
Good morning, ladies and gentlemen. My comment goes on, I had 6 months. I think 6 months is a bit late, because by the time she comes, you already have a 4 months pregnancy. I think let's emphasize this 6 weeks. The last time I stood before a class, that's what I used to teach. And I think it hasn't changed much. That's a comment. Then the other comment, I think the other comment will be made by other colleagues.
Yes, Professor Paya. So, Professor Miller, you want to say something?
I'd say before she starts up.
Good morning. It's an excuse to stand up and exercise a little bit. We congratulate Dr. Jonah for the presentation. On self-care, you emphasized many things. First of all, congratulate you for the work which has been done in the country. You emphasized many things, and I noted one or two. You emphasized the role of digital platforms. And then towards the end of the presentation, you emphasized social media or social platforms or something like that. We mix up these words. And then I was thinking of my neighbors in Amuria there, and also in Sinze, in Bugweri. No, Sinze is in Amutumba district. I grew up there, and I'm wondering about this issue of digital platforms. The women were talking about, and the communities were actually focusing on via data in the rural areas. I was thinking just how do you actually bring about this issue of the digital platforms, the social media. In the papers yesterday but one, I read an interesting story that through this web-based information, somebody moved from one part of the country to meet a boyfriend in another part of the country. It ended up not quite a nice story when they went to bed that night. So the use of the web. WHO issued guidance 2 days ago, 3 days ago, about AI and use of this information for health. Could you throw more light about this digital framework and social media for those people in Sinze, in Buko, in Toroko? Thank you.
Thank you, Professor Yamgisha.
Thank you very much. President, thanks for the presentation. One of the points that has been raised about self-care is there have been some form of undertones. I'm not sure whether you have had any form of undertones. Because you've talked about almost everything in the obstetrics, deliveries, immunization, family planning, and some people have indicated some fear that we may start from this, the ordinary one, and then some other aspects that are not allowed in the country are introduced. You need to, since you have been doing research on this, we need to see what you can tell us about that. The other one is, have you tried to translate it to the local language? Like the way you have said, what is self-care in the different local languages, so that we can understand it and be able to see how we apply it in addition to what we've been doing as routine reproductive health service provision. Thank you.
Thank you. There is a hand.
There is a mic.
And the mic.
Somebody's having a mic here. Thank you, Madam Chair. Thank you, Dr. Chola, for the presentation. You know, postpartum family planning is my passion. And I feel it should be very well implemented and stepwise.
planning is being made, is side by side. So I think the emphasis is integration of male involvement for postpartum family planning, because that is where the dilemma the women have. Thank you.
Thank you very much. Jackson is our LHU Executive Director, and we are very grateful that you are the one to bring in the male factor. Thank you.
Yes. Okay. Thank you so much. Yes. I'm so happy that so many professors in the room managed to listen and ask me questions. I'm honored. Professor Pius, I'm honored. You've taught me, you've mentored me, and I'm sure you're happy to see me here. Professor Mirende, you also taught me in FPH. Thank you for challenging me this morning. Professor Joseph, I'm honored. Dr. Mugasa, we worked together. Thank you so much for being here this morning. I'll start with the last question from Jackson, but I will call upon my colleagues. Dr. Josephine Nabukera, wherever you are, please come here. Rogers Kajimu, wherever you are, please come here. Okay, let me start with Jackson. He emphasizes the fact that we need couple counseling, and I couldn't say everything, but couple counseling was among the key things. That already shows that this lady has already made a decision that she's going to take this method. So it is not just a suggestion, it is something that we've already decided. So at antenatal, that asterisk should show we are going to, it's unfortunate that we can't keep reviewing these tools all the time. But as a service provider, indicates there, so that even if it is not you who is in the labor ward that day, whoever is just sees and probably just reminds the lady that yes, I'm cognizant of the fact that you already made a decision and I'm going to do this. So that you don't start afresh. Somebody in labor really does not have that opportunity to listen to you for the next, to make a decision. Then Professor Mirembe, I will start with you. Thank you for being passionate about postpartum family planning. You said we need to build competencies of the midwives. And not only midwives, nearly everyone in the health system, as long as they are service providers. But postpartum family planning, definitely, we look at the midwives, but also in immunization, we have nurses. So all these cadres, their competency must be improved. And it is one of the things that we already talked about, that we are going to intensify on-job mentorship so that the service providers have the competencies to be able to offer the postpartum family planning. You also raised the issue about the community. Yes, you remember in my presentation I mentioned that the women don't know about postpartum family planning. It's you and me who know. So it is our role to actually initiate it and tell it to them. So if we keep quiet, then it will not be done. So the community is also important. We have very important and ably functional partners. Reproductive health is one of them. Maristops Uganda is one of them. We have Accord
We have, I don't want to make mistake by mentioning some and leaving some, but we have partners who are helping in offering outreach services. And during outreach services, it's not just offering the service, but they also do community education. The Uganda private midwives have helped us a lot to do this. So, Professor, the community component is ably structured in that we let the community get to know. And we have the village health team who are helping us to pass this information. Professor Josepha talked about IEC materials. Yes, in my presentation, I mentioned that WHO supported us, and we have started the process of developing messages on self-care for the various priority areas. I talked about family planning, I talked about antenatal, post-abortion, NCDs, and I said that these messages are going to be translated in different languages so that people get to know them and appreciate. Women, wherever they are, should know even before they get to the facilities that there is postpartum family planning and there is information on self-care. What do they need to do? How do you behave as a woman who has woken up, you're pregnant? What are the kind of foods that you're supposed to eat? What kind of exercise are you supposed to do? How much rest do you need? How about simple exercise? You know, your mental health. If your husband has annoyed you, how do you react? How do you cope with stress? So all those small things we are saying gives you the self-care. And the next step, as I said, after approval at Ministry of Health with help of Shamina, we are going to translate in all languages. Then Professor Pius digital platform. We have what is called Dial 161. And it can be with any phone. You don't need an iPhone. You don't need a smartphone to do that. Our capability. You just dial 161 in whichever language, whatever information you want to know, you will be given. So we want to use that opportunity that self-care can reach the women. But we also have the young people. She told us the other day, that is their space. Social media. They use all sorts of platforms. But for our rural people, like you mentioned in Mayuge, and in Yamuria, in Katakwi, and wherever, we need to just help them appreciate that we have these platforms. Dr. Mugasa, 6 weeks is the best. We don't need to talk about, we don't need to stretch. But postpartum period starts from that first moment when the baby is out, and we give opportunity up to 12 weeks. But I had a disclaimer that we all know that we are women who can come back after 4 months when they are already pregnant. And that's why I emphasize the fact that let's capture them during the time of childbirth. Let's not miss out. But in case we miss, then whenever they come within the period of 12 months, we should be able to do so. Thank you, Josephine. Can you answer some questions?
Thank you very much, Roslyn, and thank you all for the wonderful questions. They really show how passionate the audience is towards family planning and the potential that has to make a dent in our indicators. I just wanted to respond to Professor Mirembe's question around how prepared are we towards midwives providing postpartum family planning, right from ANC, labor and the theater, and across the different service delivery points. Like shared in the roadmap, we have the LNMS accountability mechanisms, and I think the concept is going to be shared a little later in the conference, but that is the approach we are taking for it is a sustainable way of providing mentorships. We want to have a harmonization workshop that was requested by the coordinators of those mechanisms, and this is happening in the first week of November, actually next week. So much so that then, once we have harmonized, then they are able to add the immediate postpartum family planning onto their maternal newborn health scope, and then mentor the lower level facility providers, and that includes all providers, the midwives, the clinic officers in that space, the doctors, because like you correctly said, Professor, they actually insert the PPIUDs post C-section. So all of those will be taken into account, and then the local maternity mechanisms will be in position then to take the mentorships right down to the lower level facilities, all the levels that are actually delivering, because the UDHS showed 91% of women are actually delivering in facilities. So for all those facilities that are delivering, we want to ensure that they're actually empowered with knowledge in immediate postpartum family planning. And that's a range of a whole method mix, so that then they're able to provide services to the women that need them in that postpartum period. Thank you very much. That's what I wanted to respond to.
There was one that colleague who asked that what is self-care in the local language, and I asked the MC to tell us.
You guys are not good. Is it only me who was the local language? Yesterday we said that self-care muluso gakitegeza okwefaako ye mwene kubigemagana n'obulamu bwo. But as the discussion went on, I also learned some other thing that yes, okwefaako iwe mwene kubigemagana n'obulamu bwo aye ng'okozesa amagezi agakuweebwa abakugu kuba oyinza okwefaako bweffe aye ng'oli kwefaako bweffe oti watuuka na kufa buffe.
Can we clap? And we want to thank our Master of Ceremonies because he has started us off. And each of us will have to go back, inquire, talk with the communities and understand how they understand. Just like we began with HIV, isn't it? So it's a journey we are going to walk together. I saw 2-3 hands from that side. There is green, white, and black. Yes.
Thank you very much, Dr. Olive, and thanks to Dr. Roslyn for the great presentation. It's good that you've been able to give this presentation deeply, so that each and everyone here is able to understand more about self-care in particular. Because yesterday we had a panel, but the presentation had not yet been given. So probably maybe some of the people or some of us maybe had missed out things here and then we were wondering. So since there was inadequate time yesterday, probably some of my questions were not being answered, and I think I'm back here to ask these questions so that we can be able to have more clarification. In regards to self-care, about the quality control issue, yes, we are going out there and we are looking at the component of self-awareness, self-testing, self-management. But the quality control issue, I think, is very key, and we need to be, this needs to be clear on how it's going to be done. Then in regards to tracking and reporting, because we understand we are going to be having, of course, private clinics, private pharmacies on top of the public health facilities. So how about the issue of reporting and tracking? What are the mitigation measures that are going to be there, knowing that it's already going to be a challenge, or it's already a challenge? Then in regards to people living with disabilities, when you come to self-care, how are we going to, how can we ensure that people living with disabilities are able to also benefit from this? And then I think as I conclude, we are talking about, for example, promoting the use of these injector plants, the Sayana Press and all that, which is very good. But I'm looking at, for example, someone comes to a pharmacy and they're requesting for it, but they already maybe obese or fat, already have hypertension, and now they've just come and requested for that, and you're giving them without even knowing their blood pressure and all that. Are we doing justice to them? Are we going to put some control measures here and there to ensure that we are able to, they're able to benefit, but also we are trying to save their lives as much as possible? Thank you very much.
Okay, thank you. My name is Harriet, and I'm a midwife. I have had a chance to work with one of the largest PNFP hospitals in Uganda. And thank you so much about family planning. But we all know that PNFPs are basically faith-based Catholic hospitals, and the information about family planning is sometimes limited. I want to understand what is in plan, because we know that this facility is actually providing care to the largest population of women, but what is in plan to see that these PNFPs at least are able to give the right information, maybe through the value clarification and attitude transformation. Because what is most given there when it comes to family planning, the most emphasized methods are the natural family planning methods. What can we do best to see that these facilities are actually giving the right information when it comes to family planning? And if they are not able to give, at least can they maybe refer or transfer these patients where they can get the care from? Thank you.
So does PNFP stand for profit, not private, not for profit? Okay. Lastly, the gentleman here. Thank you.
Thank you very much, and I can officially say that getting this mic is one of the hardest things. The previous presenter, Dr. Losvin, thank you for the presentation. I think I may be the youngest stakeholder player in this house. Dr. Ignatius, as I say, and I'm an intern doctor at Gwera Hospital in Kasese. Not 13. I'm a firm believer that health is made at home and repaired in hospitals. And it's good when there's a group of people who are